So what we're going to talk in this section of the symposium is the feasibility of telerehabilitation programs in Alberta. So I will start by, I will start by defining the objectives of this session. Is first to reflect on the role of telehealth in rehab practice, and then to discuss about some challenges and opportunities of implementing telehealth in rehab practice specifically after this catalyst effect of the COVID pandemic. And then Nizam is going to focus and help us to understand his experience of implementing a neurology telemedicine program in Alberta. So then we can reflect on lessons learned towards implementing a specific telerehab programs in the province. I hope that I can make the point clear that telerehab is here to stay, and that we need to start thinking more programmatic, as well as along with the technology development, which I think Martin has touched on this. All of the presentations have touched on this. So this is going to be more about the actually how to implement all this stuff in programs to help our clients, patients, whatever you want to call them, in the community. So the first thing is, of course, let's begin with why do I mean by telehealth? So according to the New England Journal of Medicine, telehealth is the delivery of healthcare, health education, and health information services via remote technologies. It could be anything from a telephone to very sophisticated telehealth softwares and technologies. Now, let me begin by the first section, which is with me on the role of telerehab in rehabilitation practice. I'm going to share with you my stories right now, my stories and experiences using telehealth in rehabilitation practice in two settings, one in my setting in Mexico, and the other one is my setting here in Alberta, especially after the COVID-19 pandemic. So first, the pre-COVID, right? So I have been working for the last 10 years with a Mayan community in Southeast Mexico. This is an indigenous community, one of the poorest in the region. And we started going there and working, trying to improve the functioning of people living with musculoskeletal conditions in this poor community. So the journey began going as a face-to-face, right? Going there to the community every 3 months, every 4 months. Well, actually, I started this when I was doing my PhD. So I went to live to the community for almost a year first. So that was my first face-to-face, and then kind of graduate, transition back to more remote interactions. So one of the most frustrating things for me were, okay, I'm there in the community, but I'm alone, right? I'm doing my assessments, but there is no team. There is not even a culture of what rehab is, right? So that was a hard lesson to learn, because you go there like, oh, I'm going to save the world, right? I'm going to help these people to be better. Of course you can do it on your own, and of course without knowing the setting and things like that. So that led to continue, to kind of building capacity in the community. So we train people from the community in the concepts of exercise training, things like that. And then I felt better, right? I felt, oh, at least I have someone to talk to about how can we help this individual to improve their functioning and their participation in life. But that was not enough, because then I left, and then I came back every 4 months, every 6 months. We started to speciating more. And I saw that all the gains that I found at some point, then when I returned, they kind of regressed again, because there was no continuity. So that led to the need of using telehealth, right? And we use very basic stuff like Skype, WhatsApp, and Zoom, and this is pre-COVID, right? To try to communicate better, improve the continuity of care and the communication with the community people, the community members that were already educated into this, into how to deliver specific rehabilitation interventions. And I could tell you that that was a success, and we continue doing that. So the lessons learned from me here is that telehealth, or the use of virtual care, it's very good for two main things. One is clinical practice, and the other one is communicate and build communities and relationships around this. So then COVID hit. So I'm here in Edmonton. The pandemic hit, and we know that, and this has been published recently, that the pandemic has been a catalyst for the rapid adoption of telehealth practices to ensure continuity of care. As an example, again, in my story is, as a physiatrist, when I started here in Edmonton at the Glenrose, one of the challenges I faced, okay, what to do with people who live outside of Edmonton? And immediately I said, well, can we do Zoom? Can we? And I have these conversations with Chester. Chester had the idea as well. And we were like, Chester told me, that is something that we're trying to, that is a wall that we're trying to crack, right? That just, I don't know if you remember, Chester, but we were discussing about the idea of using Zoom to deliver clinical care, even in people's houses, right? And that idea has been around, but like the administration from Alberta Health Services, of course, were like, no way, right? That's not an option. And then COVID happened, and in a matter of a month, we got Zoom approved, right? So now I'm going to share with you some of the experiences that involve virtual care or telehealth in rehab that I have been part of. So first of all, I will start by the mode of the delivery, right? So the first one is phone. They bare use of telephone, right, to provide care. And this is at the Glenrose. So most of the people at the Glenrose, sorry, the providers at the Glenrose are doing this. Now, I can tell you that 80% of my outpatient clinic is now run by phone calls, right? It's not ideal, but it's what people has more access to, and they are more comfortable to, because Zoom and the other environments are still a little bit foreign for them. So that's one for the one-on-one care. And the other one that I have been involved a little bit is a project that is led by Chester and Kieran and Elizabeth and Caitlin, which I'm really glad that you're here in this workshop. And this is called the Rehabilitation Advice Line. So this is a specific phone service that was, again, formed by or created because of the pandemic to provide a service that is parallel to 811. 811, as for people who do not live in the province, it's a health line that everyone who lives here can call when you have a medical issue. And then a nurse is going to help you to navigate the system and tell you what is the best next move for you. Well, the Rehab Advice Line is something similar, but only directed to people living with disabilities and who are dealing with specific problems in their functioning. And this has been a very, very interesting service that is now up and running. The other one, going to the virtual health, this was pre-existent to COVID. Or like most of the rural healthcare centers in this province have the capacity and the infrastructure to provide virtual healthcare through very specific softwares and all the security that you can imagine. And of course, we have been using that more now. In my case, it has been more to connect with teams in rural areas, and that has been very, very important. And that's why I say here, for me, the virtual healthcare has been most, of course, for the one-on-one care, but most important for connecting with multidisciplinary teams outside of Edmonton. So that have allowed me to engage in knowledge exchange strategies and improve, so I can learn what is going on with people in their communities, and they can learn from my expertise as someone that is in a center that is specialized on a specific condition. In my case, it's a spinal cord injury and general neurology. Now, the other one, which is Zoom, right? As I told you, this picked up, and I'm really grateful for that. Has helped me greatly with the one-on-one care. When you were presenting that, that issue of not seeing the whole body or the whole person in the screen. That totally resonated with me, because that is a constant frustration for me. You just see the face and you don't know what is going on around with the rest of the environment of that person. So but still, Zoom has been very, very useful for me. And also we have utilized this to implement another strategy post-COVID, right? That is called the Alberta Spinal Cord Injury Community Interactive Learning Seminars. This is, in a nutshell, a monthly webinar that involves people with spinal cord injury, health providers, family members, in engaging them in conversations guided by the specific topics, with the whole goal of challenging those perspectives of disability, creating a community, and also learning from each other. Very, very powerful experience. I can tell you, I like it. And we are now going on through an evaluation strategy of both the rehabilitation advice line and the Alberta skills. So we will have results of how much impact we're having on these strategies. So now I'm going to move on, and I'm going to just quickly reflect on what has been the added value from implementing all of these strategies that I have been part of. So I'm getting this, the source of this data that I'm going to present come from three things. One, the evaluation that I just told you that we're doing with the Rehab Advice Line and Alberta Skills. And the other one was a screening survey that the Neurosciences, Rehabilitation, and Vision Strategic Clinical Network did in June of last year, asking providers in the province about their experiences on their of using virtual care, or telerehab, if you want to call it. And I received the report, right, from that, because I participated in it. And based on that report, I read it and I reflected on these advantages of using it. So I divided it in two main groups. One is advantages for the actual provision of healthcare, so the clinical advantages. So for them, what I found from the reports was cost reduction for both clients and the health system. Clients, because they don't have to spend money traveling, gas money. For the providers, because they could see more people in the same amount of time, meaning shifts, things like that. It saves time to both, to clients and providers. Also improves that collaboration, that multidisciplinary collaboration. As I told you, I agree with that. For providers, for me, that has been a good advantage. It improves access to services, right? But big one, and that's my passion, right? How can we improve access to people living outside of Edmonton or Calgary in this province? And of course, virtual care has been a good solution, and also increases productivity for providers. For example, today, before this session, today is my outpatient clinic. I was able to see 6 patients before seeing you coming joining here. In other setups, I wouldn't have been able to join here because I could not see 6 patients in person before joining. So that is a practical example. Now, in terms of health information services, so it improves communication among providers, a huge one. It's a good format to create those communities of practice, as I told you, with Alberta Skills. And this is without geographical limitations, right? So we can bring people together from all the corners of the province, and even beyond the province, nationally or internationally, right? And it also improves access to knowledge exchange opportunities. So now, let's talk about the challenges, right? Because I think that's the other big piece. So I'm going to still utilize those sources that I told you, the evaluations that were done, and my reflection on them. So I see if focusing on the provincial feedback that I told you from the NRV, SCN, the opportunities that I detected there were like, people were talking about guideline development. So yes, we are in new territory now, trying to implement rehabilitation interventions or assessments virtually comes into kind of like a virgin land. So now we need to start developing guidelines of how to do it and how to do it well. Also, the virtual assessment validation, right? Again, all of these technologies that we have heard so far are fantastic and hold a lot of promise, but we still need to validate that we're actually getting the information that we need to get in a valid way. Also, the opportunities is to increase regional communications. That is a very good, a very important one. And then the opportunity to create new outpatient clinics that could be multidisciplinary and without geographical limitations. That's one of the things that that we want to do here at the Glenrose in the Spinal Cord Injury Program. We want to create an outreach outpatient clinic in which we engage with teams around the North Zone, and we can provide better service to our patients or clients. Now, the challenges, and this is more, these are the challenges that were identified, but that resonate with me, is the hands-on assessments and treatments. In rehabilitation, our culture has has a main assumption or a main pillar, which means rehabilitation needs to be hands-on, right? Specifically for PTs, OTs, right? They said, like, you need to put your hands on people to help them. If not, you're not doing it. I think that is a big challenge, and that's something that we need to reflect as a group, and we need to move on, because I don't know. I think it has some true on it, but I'm not convinced that it's 100% true. I think we can do stuff, and with these technological innovations, we could be confident that we could do a good job, even if we are not touching the patient. The other one are technology and connectivity limitations. So that is something that has also to be addressed, because if we want to do a good job, we are relying more on the technology to have good connectivity. And of course, outcome measure validation. And as for the opportunities and challenges identified by the Glenrose Rehab Hospital Virtual Care Working Group. So this is these are I'm part of that group, and these are the challenges that we have identified here, for example, at the Glenrose. I just want to focus on this one that here that is called lack of adequate spaces for virtual care provision. That again, going back to my previous point of, we need to create those spaces, those virtual spaces, which allow us to reliably do our assessments, reliably communicate with our clients and patients, or with the team, right? With the multidisciplinary teams, and also reliably or that we can trust on the amount, on the types of interventions and types of assessment that we can deliver. The other one is low acceptance of, sorry, I cannot read this, low acceptance of virtual care and rehabilitation due to the assumption of has a big hands-on component, as I already touched. So that was also identified here at the Glenrose. And then the other one is low acceptance or knowledge on technology. This is very important, used by clients and families. So there has been that comment, what about people who is not tech savvy in terms of clients or family members? And that has been identified as an issue. And as I told you, for example, in my case, at the beginning, I thought that I was going to do a lot of Zoom clinical encounters, and I'm finding that people are a little bit hesitant to buy in. And I will say a 50% of the people, they say, no, I prefer phone because I don't know how to use these clicks and Zoom meetings and links and all of that. As for opportunities for the Glenrose specifically, we have identified that we need to create these spaces, these spaces to actually do a better job doing virtual care. Because remember, this is not just about a physician, it's a physiotherapist, a speech language therapist, an occupational therapist, trying to do very diverse types of assessments and guide people to do a specific activities. So yeah, we need better spaces, and we need to create and validate also communication and education efforts to increase this, like kind of sell or socialize the value of this new format of doing rehab with families and clients. So in a nutshell, what with my experiences, for me, the so what is that one, telerehab rehab is here to stay, even if after the pandemic is over, because we have found that it has a lot of value for needs that were pre-existing to COVID, right? For example, low accessibility, low interaction among people, low communication in the system. We also need to create appropriate spaces for these virtual encounters. So that's where all these fantastic workshop with all of these technologies that are emerging could find a home in order to create those spaces that we can that could be efficient to do our job in rehab. And finally, we need to create a well-structured rehab program. So if we're going to implement this, we need to do it well. As Martin mentioned, it's not just about the technology, it's also about the processes and how are we going to integrate all the data that we're getting into our decision-making strategy along with clients and people. And this goes beyond maybe the clinical healthcare, as we mentioned before. So now I'm gonna ask Nizam, Nizam is ahead of us, like, because he has developed these programs, like telehealth programs in his area of neurology, and he has done it successfully. So let's learn from him about what is it that he's doing, so then we can be more prepared to do these programs in telerehabilitation. So Sam, you just tell me when you want me to switch the slide.
Thank you, Beto, and thank you. I want to thank the organizers for inviting me here. So it's a real pleasure. Let me go back. So, I got into telemedicine quite a while ago, so almost 19 years ago. I moved from Winnipeg to Edmonton. I was the only epileptologist in the province of Manitoba at that time. I look after some of the most refractory epilepsy patients. So we're working at a tertiary care center. These are patients who really needed subspecialist care. Many of these patients started flying to Edmonton back and forth, driving to Edmonton back and forth, incurring lots and lots of costs that were there. And this is when I conceived maybe we can do something. So how can we add value to the existing healthcare system? The whole idea is not trying to develop something fancy. The whole idea is, can we do something to add value to the status quo? And that's basically what drove me to start working towards telemedicine. Beto, if we can go to the next slide. So at that time, we did not have Alberta Health Services. There were many different health care regions. Capital Health Authority is where I applied for a research grant. I basically thought that if we can do it between Manitoba and Alberta, we can provide a better care to patients living in Alberta and in the periphery who come to our clinics here in Edmonton. If you look at the specialist care across Canada, most of that specialist care is available at the southern border of Alberta, close to the US. And a big chunk of Canada does not have any specialist care. There are some specialists who would travel back and forth, and most of the time it is the patients who have to come all the way down to some of the bigger cities. If you think from a patient's perspective, if you think from an epilepsy patient's perspective, if you have epilepsy, if you're having seizures, you're not allowed to drive. So to come to Edmonton basically means that you have to find a driving escort, somebody who's driving you back and forth. That means that if you are a working person, you have to miss your work, and the person who's driving you back and forth has to miss work. The healthcare system basically pays for your specialist care, but it does not pay for your gas when you're driving to Edmonton from 8 hours or 10 hours. So a lot of people were incurring a lot of costs. So that's basically was the idea, to compare the care that was provided at the conventional clinic, that was the clinic here in Edmonton, versus people just going down to local healthcare facilities and seeing the specialists through telemedicine. So we basically devised surveys, we devised questionnaires to look at patient satisfaction. So that was one thing. The second thing was to look at the costs from a patient's perspective. The province had already set up these telehealth centers, which were most of the time not being used, not being fully utilized. So our study, this study was basically from a patient perspective. I mean, we did not have a whole lot of patients. I believe we had 50 or 60 patients. But at the end of that 6 month to a year, once the whole period was over, we found that a huge number of patients, more than 85%, 87%, I believe, were satisfied with telehealth and wanted to continue with telemedicine rather than coming to conventional care. And when I told them this was just a research study and we may end very soon, patients, in fact, offered to pay me just so that I could continue it. So they were willing to support out of their pockets. They said, we will still save money just going through the telehealth option. And when we looked at the overall, Arto Wahinma, he's in public health at U of A. So he's a health economist who did all the health economics data. He reviewed the data. And we found a significant saving from a patient's perspective going through the telemedicine option. So better if we can go to the next slide. And the next slide. The next slide. Yeah. So, I mean, after we, no, previous slide, please. Yeah. So once we were successfully able to provide this care in Edmonton, I mean, once you can do telemedicine between Edmonton and your neighboring city, you can provide telehealth to the North Pole, you can provide telehealth to any part of the world. And that was the idea, basic idea, that basically led me to work with a group in Pakistan. So Pakistan is a country with a population of close to 200 million. They did not have a established epilepsy surgery program there. So I started working with a group of neurologists in Karachi, Pakistan at the Aga Khan University in trying to see if we can use telemedicine to help set up an epilepsy surgery program in Pakistan. I also recruited an epilepsy surgeon from West Virginia, Dr. Warren Bowling, who's also one of the authors here. And so we started doing weekly three-way conferences between Virginia, Edmonton, and Karachi. And this was back in 2006. We did a number of conferences. In fact, we started bringing patients from Karachi on the telemedicine, counseling those patients, educating the patients. And in 2008, we went to Pakistan and did the first epilepsy surgeries. I mean, it would not have been possible without the telemedicine or video conferencing systems that were there. We learned a lot. I mean, the systems have significantly improved. We used to use ISDN connections, four telephone lines to connect. Sometimes the audio packet and the video packets would not be synced. So we would be saying something and our hands would be moving a different direction. But over a period of time, technology has significantly improved. We were using software and hardware called Polycom and Tandberg. And some of those units cost, the cost was $60,000 to $64,000. And now you can imagine just going on and logging on to Zoom and making a connection all over the place. So things have significantly improved. Can we move to the next slide? I then conducted, Canadian League Against Epilepsy asked me to conduct a survey to see that if I could use it in Alberta and if I could use it between Edmonton and Pakistan, why couldn't the other 100 neurologists across Canada use the same technology? So this was back, I think, in 2008 or 2009. So I conducted a survey of all the neurologists that are there in Canada. I got responses. I think I mailed the survey to 76 neurologists, and I had a majority return the surveys. So there were three main obstacles in using telemedicine. Those were identified by the neurologist. One was some people felt it was too impersonal. Now that's not, now these days with the COVID pandemic, nobody wants to be too personal. So people are happy the way it was at that time. The second thing was reimbursement, and they would not get paid. So that is, I would suggest that anytime you are to start a tele-rehab program, make certain that work with the province, make certain that there is a remuneration, that it is accepted by the province, because otherwise, if it is not sustainable, it will be very difficult to maintain that program. The third issue was liability issue. And Canadian Medical Protective Association, since the COVID, has been more lenient and has led physicians and specialists to work across the provincial borders. So that issue to some extent has been resolved. Can we go to the next slide? I mean, I probably 8 or 10 years ago, I was invited as a consultant by the International League Against Epilepsy in trying to help set up similar programs that we had between Pakistan and Canada to see if we can use other universities across North America, that we can create partnerships between South American countries and North American countries. And you can see the different countries that were involved. So we were able to successfully launch a telemedicine program and a collaboration program between major universities across the two continents. And it was very successful. I mean, telemedicine was not the only way that they were communicating. Telemedicine was one way. We had visiting professorships and we had many other means of communications. But the telemedicine was one big connection that made it successful and made it possible. Now, in anticipation, I know I'm running short of time here. In anticipation of our mini symposium, over the last little while, I started asking patients that what from their perspective. So I did not do a formal survey. It was just basically jotting down questions from the patients and getting their opinions. I said, how did the telemedicine really help you? Using the telephones that we are using, the Zoom technology that we're using, has that changed anything for you? So I've scribbled it down on some pieces of paper. So I'm going to read out some of the responses from the patients. A number of patients told me that child care was a big issue. Previously, coming to the K Edmonton clinic, they had to make arrangements for their child care, and that's not an issue anymore. Patients tell me that they do not have to find a driving escort because I'm calling them at their homes. A number of patients would receive the calls at their work, so they don't have to miss work. They'll go into a secure place at their work, take my call, do the 20 minutes to half an hour session, and then they can continue back to work, so they are not missing work. They do not have to find parking. Some of the patients say a biggest challenge was trying to find where was the parking at the K Edmonton clinic, and finding a parking and paying for it was a hassle. I have a lot of patients who are who have developmental issues. And it was very stressful for some of those patients to come and sit in these waiting areas and come and see us. So it is less stressful for patients coming here. As Beta, you pointed out, it is less costly for people coming from out of towns, driving back and forth. Patients have told me that they are not scared of catching COVID or other infections from the waiting areas. So even before COVID, there was a lot of flu and all those kind of things. Somebody's coughing, sitting next to you. So that was a big issue. Convenience, of course, is everyone realizes, I don't have to say that. It is a way more convenient system. From a physician's perspective, there are way less no-shows. We used to have a lot of no-shows if there was a blizzard, if there was a snowstorm, if there was a bad traffic situation. There will be so many no-shows. So there are way less no-shows. There are still some telephone. I call them once, and if there is an answering machine, I call them back in 5 to 10 minutes. And then I do get connected in most of the cases. Now, something else that was brought on by some patients that's very interesting. Some patients told me that they find that the privacy is way more respected on the telemedicine than it was coming in and sitting in my waiting areas. So people know that I'm an epileptologist. I deal with people with epilepsy. And if I call somebody's name, everyone in the waiting area knows that this person has epilepsy. Likewise, my colleagues who deal with HIV, if they call out a person, automatically, no matter how confidential you want to keep it, somebody calls you, an HIV doctor calls you, everyone knows you have HIV. So, or at least you are being evaluated for HIV. So patients told me that, they found that privacy, they feel that their privacy and their confidentiality is more respected with telemedicines. The other thing that we've seen is the appointments with telemedicine, because of a lot of those formalities are not there. They don't have to go for all those registrations and things. The appointments are relatively shorter. And because of that, I have been able to see way more patients than I used to previously, and that has significantly cut down the waiting times. Another issue specific to COVID is patients who have autism. So epilepsy and autism go hand in a number of patients, and developmental delays and physical and mental retardation is common in our patient population. Coming to the K clinic with masks on, if you expect those patients, autistic children, to put on masks, or autistic individuals, they just can't do that. And having those patients come to the clinics with and the time of COVID has become almost impossible. So providing that care through Zoom and providing that care through teleconsultation has been basically a miracle for these patients, and they've really loved it. Now, with all those advantages, I find that there are some disadvantages, or at least from patients' perspective. So a couple that I would mention: patients who do not speak English in the past, or who speak broken English. In the past, when they would come to my clinic, we use a lot of physical cues when we are communicating. And those physical cues are not as effective when you're using Zoom and you're calling somebody on the telephone. So that has become an issue with some patients. It's a very, very small minority, but it has become an issue with some patients. And some of my senior patients who are not as tech savvy have issues with Zoom, but they are comfortable with the telephone consultation. So we've done that. Beto, if we can go to the next slide. So basically what since we have a lot of time constraints here, I will say telemedicine is very feasible, it's very timely, and it really is a great service to your patients. I strongly recommend everyone who's not tried it to consider using telemedicine. You will learn with experience, your patients will be happy, and you'll be a happier person. I guess I'll leave the questions for the roundtable, but thank you for your attention.
Thank you very much. Actually, I do think we have a couple of minutes for questions now. The next talk was not scheduled until 4:25, so about 5 minutes. As Martin said, really wonderful example and truly pioneering work. Is an excellent example of use of telemedicine. Marilee asked a question though: how do you provide clients with specific equipment they don't have at home? Does there need to be some sort of a rental system set up? Any comments on that?
So Beto, you want to take that question, or?
I don't know, like, does this mean like equipment for assessment, equipment for rehab, like for therapy?
I was thinking rehab equipment. I mean, a lot of PT clinics and OT clinics, they have specialized equipment, or you have FES systems like at the Steadward or that. So if your person's in their house, they don't have access to that. So that's what I was thinking of. And
that's a great point. That's what, for me, is one of the main issues with telerehab, is that we are limited by the equipment available. However, to answer this question, I think we need to situate it in the context, because we can use virtual care or telerehab like directly to people's homes. That's one thing. One of the things that I have been using with Zoom, and of course it comes from like at the moment, at the heat of the moment. So I ask people, hey, can you use your cutlery? Show me how you're using this, right? But that is more for assessment. Of course, I'm not, my experience hasn't been on delivering a specific exercise program, for example, which that would be a very different ballgame. However, I don't know if this could be kind of transferable to a physio saying, hey, grab stuff from your home. The physios are very good at that, and OTs, like prepare, right, our session, grab these things, right? Again, guidelines, right? Grab these things, and we know that with these things, you will be able to do a specific thing. Now, with the technology, I don't know. And that's for the audience here. Like, technologically, think about those possibilities that we can have in order to foster this type of interventions. The other big setting is, of course, the clinic. So that means you're doing virtual care, but in another clinic with another team, right? And for that one, I think we're more ready, right? For that one, because we assume that if you go to a private or a public healthcare setting in which you have a health professional in there, the equipment should be there. And if not, we provide it. For example, Martin has lots of experience in there, like bringing the equipment that is necessary to improve the communication, right? Or to do the tele rehab episode. but also, but he does it in centers, not in people's homes, right? So that is another setup. I don't know if that, like Nizam, in your perspective.
So Beto, I mean, the other thing that we can always think about is what are the alternatives? I mean, we may not have the perfect equipment that is there, but as you mentioned, I mean, basically just observing how they do certain things. And I mean, even for neurological examination, when I'm doing a neurological examination, distant examination, I mean, this is basically picking up a book over their shoulders, doing certain activities in front of me, and just guiding them. So we have to start thinking about alternatives or cheaper alternatives that some people will be able to afford. And if they cannot afford at home, I mean, it will still be way convenient for patients to go to local centers. So we are very lucky in Alberta and in pretty much across Canada and many centers here that there are smaller telemedicine centers that are available where people can go, which may not have all the fancy equipment, but they still do have some equipment, I think, that can be utilized.